Welcome to A Deadly Silence. I'm your host, Larry Curtis, and it is the mission of all of us affiliated with this program to bring to you current and educational information associated with alcohol and drug addiction. Our guest today is Dr. John Kelly. Dr. Kelly is Associate Director at the Center for Addiction Medicine at Massachusetts General Hospital. In addition, he's a clinical psychologist, an addiction specialist, also Director of Addiction Recovery Management Services, and Associate Professor of Psychiatry, Harvard Medical School. Dr. Kelly, welcome to our program. Pleasure to have you here.
Thank you for having me.
I also understand that you are on the Board of Directors of Learn to Cope.
That's right.
That's true?
Yeah.
Okay.
Yeah.
Can you tell us a little bit how you became involved with Learn to Cope to start off? Because that is a local-based program here in Brockton, and Joanne Peterson has been a former guest on our show here. So how did you become involved with the board?
Well, initially, a number of years ago, Joanne Peterson asked me to come and speak at a Learn to Cope meeting that they were having. It might have even been in Brockton, actually. And I was very happy to come along and share my knowledge about addiction and treatment and recovery with the group. I was very impressed. I was very impressed with with what Learn to Cope was doing, and I felt that there was a great need for it. And so I said to Joanne, I said, hey, anytime you want me to come, I'll come and do it. So I've kind of kept the connection, and I've talked to, I think, all the groups now, and there's new ones starting all the time, which is great. Bad and good.
Well, yeah,
bad that we have the need for it, but good that there is
that there is the ability for family and loved ones to be able to come together in a group and reach out and share what's going on with their lives with the addiction issue. That's common.
And then Joanne recently asked me if I'd be a volunteer board member. So I was very happy to say yes to that, because I think Learn to Cope is a good organization, and I want to help it in any way that I can to help it grow, because I see it helping parents who suffer so greatly.
So tell us a little bit about your program at Mass General Hospital and how it is coming together in relationship to the opiate addiction issues that's prevalent here throughout the South Shore.
Yeah. Well, we've seen, as you know, not just regionally here in the greater Boston area, but also nationally, we've seen this huge increase in this opiate epidemic that's happened, with beginning with psychotherapeutic drugs. These are OxyContin and Vicodin and Percocets, which are available mostly in a lot of homes around the country, that young people in particular get a hold of. And because they're very seductive, the effects of those drugs are very seductive, and they're perceived to be safe, is the bad aspect of them.
Proceed from the standpoint of the medical community, or from the pharmaceutical distributors,
or the kids,
the users themselves?
Yeah, they perceive them to be safe because they got them from their parents or a friend's parents' medicine cabinet, for example. And so they're more likely to try them. In fact, nationally, cannabis has always been the number one drug of young people of illicit nature.
The gateway drug, as they say out there.
Yeah, and a very commonly used illicit drug among young people. But opiates now, psychotherapeutic opiates, these OxyContin and oxycodone, et cetera, is now very close to marijuana in terms of new people starting. That's often the first drug that the young people try. And because the cycle to dependence with those drugs is much more rapid than it is with marijuana, for example, people find themselves getting hooked into that drug much more rapidly, and this is why we've seen this big problem. And of course, because of the lethality of those drugs, it's very easy to overdose on those drugs. And that's why we've seen such a huge problem with overdose deaths nationally. Now, opiate overdose death is the second leading cause of accidental death nationally, and it's the leading cause of accidental death in 17 states for young people.
We understand here in Massachusetts that approximately almost 2 people a day die from an opiate overdose, from across the Commonwealth.
Yeah.
That's pretty staggering.
Right.
What are the signs of opioid addiction? I mean, are there signs out there that the parent can be made aware of?
Yeah. Well, I think the earlier warning signs would be any change in mood or behavior that you think is not typical. So with young people in particular, there's a lot of changes that go on, physiologically and biologically, of course, as people go through this adolescent period and young adulthood. But outside of that, if anything seems strange in terms of your child is sleeping more than usual, they're nodding off at strange times, you might see their pupils constricted, you might see strange paraphernalia in their belongings. You might see your own. Be careful with your own if you have any stash of, not stash, but any
prescribed medications you may be taking.
Prescribed medications at home that may be going missing, money going missing, etc. Those are some of the early warning signs of opiate addiction. Or potential opiate addiction.
We talk about the potencies of the different drugs that are out there today. On your clinical research side, basically speaking, how was it that the pharmaceuticals manufacturers were able to produce such a potent drug that was almost hooks you almost the first time you take it? Have you found out what's happening in that vein?
Yeah, well, it's another one of those cases where you get a drug intended for its therapeutic purpose getting diverted and misused. And this has happened for a long time, right? In terms of, Valium in the 60s, that became a problem. And now we have these painkillers, analgesic opiates, which have become a problem. And also stimulant drugs are getting diverted, intended for example, attention deficit hyperactivity disorder. Those also get diverted, but they don't have the lethal, it's the overdose potential of opiates that nobody really saw coming, that these drugs would be so seductive to the human brain, because they're really essentially very effective painkillers, but at the same time produce that euphoria and psychological escape that humans tend to like. And young people, when they're exposed to that, like that seductive effect and can get hooked very quickly. I don't think anybody really saw that coming.
So somewhat the advancements in medicine and the scientific technology out there to combat the longer life cycle that we're now experiencing out there and the pains that go with growing older, in essence, an offshoot of that success is we've developed a medication that is now being abused, because somebody else figured out a different road for that medication to be used.
Right, exactly.
In this concept of standard treatments for opioid addiction, what does your research find that works or doesn't work, more importantly?
Yeah. Opiate addiction is a chronic, you can think about it as a chronic relapsing condition, like most other addiction problems. Not everybody with an addiction problem has a condition that is chronically relapsing, but for those that end up in treatment, typically that's the course that it takes. People tend to have 3 to 4 treatment episodes on average, and over a period of several years before they eventually cycle out and get into full sustained remission and recovery. The effective ways, methods, modalities of treating opioid addiction are substitute prescribing, so these would be methadone, buprenorphine, and residential treatment facilities.
When you talk about a substitute like a methadone, is that potentially forming an addiction to the methadone versus it's a substitute, basically?
It's a substitute. Yeah. So typically with substitute therapies like methadone, you can stave off cravings by producing a much longer half-life to the drug. And it also means that if you take street heroin, for example, or a street opiate, you won't get any extra benefit from it. So it blocks that effect. Because it's already, methadone, for example, already is fully occupying that opiate receptor in the brain. Buprenorphine is very similar, except it only partially occupies that. So it's a little bit less potent, as it were, in terms of its ability to fully, agonize that.
If somebody was, in essence, taking methadone as a substitute, so to speak, and they were to take a heroin dose or something, is there a potential of overdosing, or
Yeah.
with so the methadone just acts as a block to the receptors, but they could still overdose
Yes.
if they came up with
Right.
street heroin,
Right,
basically
right,
speaking.
right.
Okay.
Yeah.
How does the Suboxone work? I mean, you hear that opioid addicts, one of the treatments is the Suboxone. You know, how does that work?
Yeah. Well, Suboxone is a mixture of naltrexone, which is an antagonist, and an agonist, which is buprenorphine. And so that's mixed at a ratio of 3:1, buprenorphine to naltrexone. So you have this kind of a clever mix, if you will, of the agonist, which reduces cravings. When people, oftentimes, particularly with opiates, is that they have very strong cravings early on in early recovery, in the first 90 days, first 6 months. So to help people with that craving, if you give them an agonist, a much longer lasting agonist, like buprenorphine, is that it just takes away the edge off that craving, which is kind of the brain trying to re-regulate itself, which is very difficult in early recovery. So that's what the buprenorphine does. It helps take away those cravings using that longer lasting. The naltrexone is in there to prevent people from crushing it up and using it or misusing it, because then that will take effect and block the effect of any opiate that's taken.
Are there stereotypes or myths out there in relationship to using the opioids out there and so forth? I mean, what type of myths or stereotypes have you heard about in the course of your research?
Well, one of them, of course, is that you can't get addicted with one dose.
Right,
Yeah, but you have to start somewhere, right? If with these drugs, it's really better not to even try it, because you don't know whether you're the kind of person that will get quickly hooked. We know that many, many young people, nobody plans on becoming addicted to alcohol or another drug, opiates. But for some people, that's what happens to them. And with these opiate drugs, like I said, they are particularly addicting, if you like, right, if you will. Particularly seductive. They produce this euphoric effect, which people find themselves wanting to repeat. And so they repeat it because of the accessibility, they're able to repeat it. And then they find themselves quite rapidly getting hooked on it. It becomes more important. The drug becomes more and more important to them, at the exclusion of other aspects of their life. More important than family, more important than money, more important than school, than education, than work. And that becomes the central focus very rapidly with these drugs, more so than other drugs.
Have you seen, is there a genetic relationship of, if you have addicts in the family history, past or present, that you may be more susceptible than maybe not if there's a non-history of addiction?
It does increase your risk between 4 and 8 times if you have a parent or a blood relative that has an addiction problem. Your risk of addiction yourself is increased 4 to 8 times. So it is genetics play. We're starting to identify with better and better studies now the exact risk that's conferred by this genetic predisposition. But we know it is there, so if your family history is one of addiction, presence of addiction, then you probably want to abstain to minimize your own risk of getting into trouble.
Okay. In the relationship to legislation out there, whether it be local, state, federal, you're at Mass General Hospital, so I'm sure to think from the Commonwealth of Massachusetts point of view, are there legislative initiatives out there to support the research aspects of what you're doing out there, both clinically as well as medically speaking?
Well, that's a great question. You would really hope that the science would, what we learn from our research dollars, which are taxpayers' dollars, which go to the majority of the research that we do through the National Institutes of Health, would be used to inform our policies, but that's not always the case, unfortunately. So there's a bit of a disconnect oftentimes because there are different agendas at stake for public health versus political aims and so on. And so it's complex, but certainly it is nice to see. I think in Massachusetts is a good state to be in that regard, in that it does pay attention to research and what is found in science, and I think that's a good thing.
Your particular Center for Addiction Medicine looks to improve the quality of life for adults, adolescents with substance use disorders and their families. What's the family connection that you're seeing, with an opioid addict out there? What's happening?
What's happening in the family?
Yeah.
Well, the family gets severely disrupted when you get someone addicted to opiates. Their parents are very, very distraught. Typically, parents and loved ones are incredibly distraught because they don't know whether maybe they've seen their son or daughter or loved one overdose in the past. They become incredibly distressed to the point of oftentimes themselves becoming psychiatrically ill through worry, depression, the unpredictability.
It's almost like the family and loved ones become an addict themselves in trying to address the addiction problem of that
they
loved
become
one.
obsessed with their affected loved one. Absolutely, they become completely obsessed with, because they're so tethered emotionally to the person that they love and care about, and that makes it incredibly disturbing because you're dealing with the volatility and unpredictability and the very grave nature of addiction.
And that love, that affection for the addict that is, a immediate family, a loved one, almost rolls into an enabling situation. What have you experienced from the standpoint of families who think they're helping, the loved one, but in essence they're potentially enabling them?
It's very hard. It's a great point, this whole issue of facilitating versus enabling, facilitating recovery versus enabling the addiction. And it's very hard to see the wood for the trees. You're so close to the situation, it's very hard to be objective. And every single parent or loved one of an addict wants to help them. They want to help them and help them get into recovery. And they don't see how they may be setting them up for more of the same. That's why it's very important to get outside input, even speaking to another parent who's been through it, to get some objectivity, to get some input into the
learn
family.
to cope type setting,
Learn
meetings
to cope,
of
absolutely.
families, working with one another
Yes.
and sharing very similar experiences. But somebody that literally understands the pain, the suffering, the embarrassment that maybe they're experiencing at that point in time.
That would be the ideal, to be able to speak to other people who've gone through this exact same problem. And Al-Anon, Nar-Anon, Learn to Cope, our program at Mass General Hospital, we have a parent coaching